have been augmented somewhat, and we are fortunate to have the principal from Wakely, who's been the Wakely actuarial firm, who's been working with us on this for several months. And the plan for this afternoon is, after a brief introduction, we will ask Julie from the Wakely firm to go through their findings and present the various options that they have looked at. And then we will throw it open for questions and comments. I would like to ask those of you who are on the call but are not state employees to please identify yourself.
Good afternoon, Superintendent. This is Sarah Orange with AHIP.
Thank you.
Good afternoon. It's Melody Schrader with the Pharmaceutical Care Management Association.
Thank you.
Good afternoon. It's Courtney Reed with CVS Health.
Thank you, Courtney.
Ebony Liggins with AHIP as well.
All right.
Good afternoon. It's Regina Stivers with PCMA.
Okay.
Yolanda Miles, True Health New Mexico.
Oh, who are you with? I don't think I know that name.
Very funny.
Thank you and welcome, Yolanda.
Hi, this is Legina Mendez Harper from Prime Therapeutics.
Thank you.
Jacob Wager with Cigna.
Welcome.
Trey LaFleur with Molina Healthcare.
Hey, Trey, thanks for being on.
Brenda Gaetan with Blue Cross and Blue Shield.
Okay, thank you. Anyone else?
David Keewer, Molina Healthcare.
Okay, thank you.
And this is Sonia Pignate, Molina Healthcare.
Welcome. Okay, would the other state people identify themselves?
Donald Godwin, Dean, College of Pharmacy.
Thank you, Dean, and welcome.
Melissa Gutierrez with the Office of Superintendent of Insurance.
Thank you, Melissa.
Colin Bio with Office of Superintendent of Insurance.
Welcome, Colin. Anyone else? Okay, well, if you've read the summary, you know our situation here. The legislature passed House Bill 292 last spring, or last winter, I should say. Signed into law in early spring, and the provisions of 292 are really twofold. One, that it imposed a monthly cost sharing cap of $25 per month for generic or preferred drug insulin products. That provision takes effect January 1. The second major provision of the bill was that it established a study committee to look at, quote, to examine, quote, at a minimum, the benefits to New Mexico consumers and the potential costs of setting cost-sharing limitations for the following categories of drugs. And there are 9: inhaled prescription drugs used to control asthma, oral medications for treatment or control of diabetes, injectable epinephrine devices for severe allergic reactions, opioid reversal agents, medications used to treat hypertension, antidepressant medications, antipsychotic medications, lipid-lowering agents, and anticonvulsants. So at a minimum, those were the 9 we were specifically charged to look at. What has happened since this provision of the law went into effect is that we made a data request with the assistance of the actuarial firm we contracted with to help us, the Wakely actuarial firm. We made a request to all the carriers, as well as the state health plan, to provide us information on their cost sharing and their spending on these 9 categories of therapeutic products. So the Wakely group got all that information. There were, as there are in any data call, there was a need to ask questions and get some clarification. And we want to extend our appreciation to the hard work the Wakely folks have done. The lead on that is Julie Pepper. And Julie, I'm hoping you are on the line.
Yes, I am. Sorry.
Okay.
Slow to unmute.
Yeah. So that's Julie with the bright orange walls. And we are going to ask her to just walk through the process of what they did, to outline the data metrics, and then to present some of their analysis and finding, and also scenarios that they were asked to consider. I want to, before we get started, be very clear that even though the advisory committee has to do a report next Thursday, October 1st, to the legislative leadership and the governor's office, we have not made any decisions at all about what is to go in that report. And one of the reasons for that, of course, is that we wanted to have an opportunity for stakeholder input. So we are going to listen carefully. We welcome all input. And with that, Julie, I'm going to turn it over to you.
Thank you, Superintendent. And my neighbors just started getting their lawn service started, so hopefully you'll be able to hear me. Okay, but let me go ahead and share my screen in a moment. But first, I do want to reiterate what the superintendent said and pass along appreciation to all the insurance companies for providing us information and answering all of our questions, because we were very persistent with our questions. So appreciate all the thorough and quick responses we received from them. And I know a few of you are going to be seeing this for the second or maybe even third time, so I can't promise it'll be any more enlightening or exciting, but I will try to at least keep things interesting for you. So as a superintendent, there's information has been shared on this. I believe there's some exhibits on the website. What we'll be going through today is an updated version of that, which I believe will be distributed in some form later after these discussions. For the most part, the data is the same. We've just added some additional exhibits. However, we did, again, in conversations with the insurers about some of our questions regarding the data, did make some minor adjustments to the data. So it won't be exactly to what's currently been posted online or distributed, but nothing significant has changed, mostly minor tweaks here and there. So as noted, we did do a detailed data collection. We requested from the insurers and the state employee plans claim level detailed data at the NDC level for the 9 drug categories that were listed in House Bill 292. So we didn't want to collect all the data because we wanted to make sure that we also focused on looking at different types of plans. So we asked the insurers to provide their largest, 5 or so largest plans in each of the individual small group and fully insured large group markets. And we received a sampling, we ensured we received a sampling of, for example, for the ACA plans, a bronze plan as well as, gold and silver, as well as the CSR levels, so that we can understand what the impact is by those middle levels as well. And we won't be discussing that in the call today, but we will have that included in the report since we do expect the impact by plan to vary. So once we received that data, the first thing we did was check it for data. And again, that was with some of the follow-ups we had with the issuers. And we'll kind of go through some of that, looking at the historical data, because we let the historical data drive some of the scenarios that we looked at. So, we'll talk about the data that we looked at, but we wanted to look at, okay, what is the current utilization by different drug tiers? What is the average cost sharing right now? And how does it, and what's the distribution of cost sharing for the members for these drugs? So really understanding kind of what consumers are typically paying out of pocket for these different drug categories to help kind of guide where we wanted to set the different potential different limits in cost sharing going forward and for this analysis. So before we go through the data, I did want to caveat a couple of key things as we kind of talk through the data. Is Wakely did make some assumptions around what drugs to include that would be associated with these 9 drug categories. So we mostly used Metaspan to map from the drug categories to an NDC level mapping that we provided to the insurers and asked them to give us all of the drugs listed in that NDC mapping. In discussing with some of the insurers when they were providing the data back, it's clear, and we were aware of this, that some of the drugs do have multiple uses. For example, some drugs that can be used to treat asthma can also be used to treat COPD. So, we recognize that by, having a list of NDCs for these drug categories, it's possible that there are other conditions that are not necessarily listed in House Bill 292 for which we've collected data and which might be impacted by this as well. So to the extent that either we should be excluding these NDCs or including them, we did not make that decision. We're actuaries, we're not clinicians or pharmacists, but just wanted to be clear that all of the NDCs are currently listed in the analysis. And based on a list provided by one of the insurance companies, roughly about 25% of the allowed claims in our analysis are for drugs that could have multiple uses. So to just kind of keep that in perspective. And it comes from mainly 3 different of the drug categories out of the 9 in House Bill 292. The other thing I want to mention is that, all of the insurance companies have a different drug tier structure. So, some have 2 tiers for generic, a generic preferred, a generic non-preferred. Typically there's a preferred brand, non-preferred brand, but there's, sometimes, 6 to 7 tiers, sometimes 4. We wanted to have some consistency in this analysis to make it easier to look at. So Wakely did take some liberties in mapping the different drug tiers that we had on the data to a consistent set of drug tiers that you'll see us listing, specifically generic, preferred brand, non-preferred brand, specialty, and preventive. On the state side, we did look at their data separately. 1, it's a different program, and 2, they had a significantly different tier structure, which was generic, brand single source, and brand multi-source. So we do look at those 2 separately as we go through this. So I think those were kind of the key things I wanted to mention. The last thing I'll mention is, again, as we're going through this, we'll be talking about a lot of averages. At times we look at distribution, but when we impacts, we're really talking about averages, but we expect that those averages could vary significantly. So as we looked through the data, we noticed, for example, the portion of scripts that were already being at $0 cost share, that percent varies significantly by insurance company. In following up with some insurance companies, they already have kind of a $0 cost sharing program for certain maintenance drugs, where others don't yet have as broad of a program. And so, you see a pretty wide range of kind of where they're at currently. So this will impact insurance companies differently. It will also, again, as I mentioned, a really rich plan design versus a less rich plan design will be impacted differently as well. So just keep in mind, we're talking averages right now, but the variation could be different among insurers, plans, et cetera. All right, so now moving to the numbers, and I'm an actuary, so there's a lot of numbers we're going to go through here. We collected, again, this is not the entire New Mexico commercial market, but this is the largest plans from the insurers in each of the individual small and large group markets. So again, we've combined them all for now for ease of use into commercial lines of business. And again, we separated out the state employee plan. So what you can really see here is just for the 9 different drug categories listed in House Bill 292, the number of members that have a script in that drug category, the number of scripts that's in the data that we have, the paid claims, the cost sharing, and the scripts per member, paid per script, and cost sharing per script. And the difference here between the scripts per member and the scripts per member per 30 days is, you know, a lot of these maintenance drugs have 90-day fills. And so we wanted to make sure that we captured, especially as we talk about compliance, and that, you know, ideally be one of the goals of House Bill 292 is to make, you know, drugs more affordable so that people that have, you know, chronic conditions are filling and taking their maintenance drugs. You know, what is the current kind of compliance right now, or how many, you know, average scripts per year are these members filling currently? So what we did essentially is for those that had a 90-day supply, you know, would convert that into 3 scripts in this column here. So you can see that, you know, for conditions that are more, you know, need more maintenance drugs, you know, the diabetes, hypertension, antidepressants, they tend to have the higher average scripts for the year. Very similar on the state side, with the numbers actually being a little bit higher as well in terms of the average scripts per 30 days. The next piece of data that we looked at to help us kind of understand it was what is the current cost sharing distribution for each of these 9 categories. So we looked at what portion of scripts are already at $0, how many are, you know, more than 0 but less than 10, between 10 and 25, etc. So this actually surprised me, was that right now already in the data that we collected, roughly 45% of scripts in these 9 categories, again, it varies wildly within the 9 categories, but overall in total, you know, a little less than half of them are already at a $0 cost share. And again, this is the number that was pretty significantly different by insurance company. And another 40% is between 0 and 10%. So, you know, 87% of the scripts that are being filled or were filled in 2019 for these drug categories had a copay of less than $10. Very similar numbers on the state side, except there's less than the $0 level, but more at the $10 level. So overall, it's close to 80% that have less than $10 on the state employee plan side. You know, so you can see when we're talking about, you know, we'll be talking about $10 and $25 amounts in the scenarios that, you know, when you start getting over, you know, $25, there really aren't a whole lot of scripts that are potentially impacted in those 2 categories. And again, this was more for informational purposes. Someone asked about the day's supply for each of these categories, again, related to compliance. So not specifically related to what we're talking about, but we did pull the data to look at days supply as well. And so you can see again for the more maintenance related categories, a much higher percent of the scripts are happening at the 90-day script level. And again, we've bucketed in by day supply just to get it, and even more so are using the 90-day supply at the state level. And one thing that I think I failed to mention before is that House Bill 292, the cost sharing limit is based on a 30-day supply. So to the extent that, say, the day's supply limit is $10, it would be $30 for the 90-day supply. So that's how we're kind of interpreting House Bill 292, since it's based on kind of a 30-day supply rule, that we would adjust that limit for higher day supplies. The other thing that we wanted to look at is, because the insurers had provided some initial feedback when we were requesting the data about what drug tiers would be included in the cost sharing limit. Again, the House Bill 292 talked about the tiers for the diabetic supplies and the insulin, but they didn't necessarily specify for the 9 drug categories. So there was some concern that this would apply to non-preferred brand or to other categories that would be difficult then to encourage consumers to, buy down to the generics or the drugs that the insurance companies, have lower paid costs, et cetera. So we wanted to look to see what was the current distribution of scripts by the different tiers for each of these 9 categories. So you can see that already for a lot of these scripts, you have over 90% utilization already in generic. And you can see that this is where the average cost per cost sharing per script is significantly lower. When you get to the preferred brand and the non-preferred brand, the cost sharing ticks up as expected. So again, a lot of service categories that are close to 90% or above in terms of the number of percentage of scripts that are getting filled at that level. A couple of exceptions to that are the inhaled drugs to control asthma, a much smaller percentage generic, the majority being filled at the brand preferred at the higher cost sharing level. So when we start talking about the impact of the different scenarios, this is one bucket that will be impacted more so than some of the others. Severe allergic reaction, still high generic, just not as high as the others. And then lipid lowering agents, this is where it's on the ACA preventive list. So actually there's quite a few that fell into the preventive tier as well here. And if everything was perfect, that would be 0. There's always some data issues there, but essentially the preventive list has $0 cost sharing. And then the generic is a little bit lower. So again, combined still well above 90% for that category. And then opioid reversal agents, only about half of them at generic, but the rest are preferred brand. And again, cost sharing typically goes up when you get to the higher preferred levels. Very similar story for the state employee plan, and they have a different tier structure as noted. They have a generic, brand multi-source, and brand single source. So again, very high percentage script counts at the generic level. Interestingly, they do not have much utilization at the brand multi-source. So you will see, especially when we get to the inhaled drugs to control asthma, that we're initially, on the commercial side, going to apply the regulation for the analysis to generic and preferred brand only. On the state side, the intent was to apply to generic and brand multi-source. Given that would only capture about 20% of the scripts for asthma, we did do a third scenario that said that it would apply to all tiers for the 9 drug categories. So it would apply the cost sharing limit to brand single source as well. But again, most of them are very high in terms of generic utilization. Opioid reversal agents also close to 50%, similar to what we saw on the commercial side. Then the next couple of tables were based on a request from someone in terms of just understanding what drugs were included in each of these categories. So we pulled the top 10 drugs, looking at it a few different ways. One, which drugs had the highest utilization, which drugs had the highest allowed amounts, and which drugs had the highest cost sharing. So again, just kind of different views of looking at in terms of which were the top 10 drugs for each of the drug categories. Specifically, someone had asked about albuterol in terms of how much that accounted for in terms of this category. So there was a couple of, they fell twice on the top 10 list. So again, just understanding, which of the 10 drugs, and there's a couple categories that only had a handful. There's only a few opioid reversal agents. And same thing on the state employee side as well. Then finally, we start getting to the scenario results. So, as we talked with the state and the advisory group in terms of, what makes sense to use in terms of looking at scenarios based on kind of where current cost sharing was falling, and also the potential to maybe differentiate generic versus preferred brand. There's some concern about cost shifting. If it's the same cost sharing limit for both generic and preferred brand, that some of that high generic penetration might start leaking over into preferred brand if consumers did not have incentive to stay at that generic level. In one of the prior calls, there was some discussion around maybe having a consistent cost sharing limit for both generic and preferred brand, which would allow the insurers some flexibility to have a lower generic, but they would have that flexibility to do that on their own, as opposed to having it as part of the regulation. But based on the conversations with the state and the advisory group, we modeled 4 different scenarios. So the first is, I say copay here because when I think of something like $10, I think of a copay, but it really is limiting the cost sharing. So even if this person, a member is in a deductible type plan, and they have not met their drug deductible, they would still be limited to that $10. So it almost, in some ways, waives the deductible for these specific drugs, if you want to think about it that way as well. But the first scenario would be to limit the cost sharing for both generic and preferred drugs to a $10 maximum for a 30-day supply. The second scenario does the exact same thing, but limits it to $25. The third scenario limits generics to $10, but preferred brand to $25. And then the final scenario would require generics to essentially be offered at a $0 copay within these 9 categories, and for a $10 maximum cost share for preferred brand drugs. So what we did, and I'll actually go to the next tab and kind of walk through more of the details of the scenarios, is for each of these 9 categories, we had kind of what the baseline cost sharing was, as well as the cost sharing per script. And then we went through each of the drugs and the data, and we said, okay, if it's over $10 and you're a generic or preferred brand, again, we took liberties, if you'll recall, in terms of how we mapped all of the issuers' data. But if you're over that cost sharing limit, we're going to cut it off. So, what this is showing is essentially how much cost sharing was reduced based on applying that $10 maximum copay or cost share for generic and preferred brand drugs. So you can see that it drops at about $2 million in terms of the cost sharing is based on the data we have. So the revised cost sharing per script goes from $88 to around $4.50. And you can see some of the ones that had a really high generic concentration, such as these first 2 rows, the impact is a little bit less, where, as we looked at, for the inhaled asthma medication, much more significant impact because that had a much higher preferred brand utilization and higher cost sharing as well. So you can see that it is appropriately impacting those that had the higher cost sharing to begin with. So the change in cost sharing, again, varies for the 9 categories. And overall, for the 9 categories in total, it would reduce the cost sharing about 44%. In turn, that would increase the amount that the insurance companies have to pay by 11.2% if nothing else changes. So a couple of comments on that is that this analysis is really just focused on what the impact is to limiting that cost sharing. There's several other factors that might come into play in terms of what the ultimate impact is that we aren't necessarily modeling. One is, one of the goals of House Bill 292 is to encourage compliance with maintenance drugs. So, you almost hope that you have, actual utilization increasing. And you might have it increasing, we call it induced demand. The lower the cost sharing, the more likely that services will be used or scripts will be filled. Another one is, again, the cost shifting. If there is cost shifting from, generic to brand or otherwise, that might also change the impact. To the extent, I think the hope is that if these members are more compliant, there might be savings. If a diabetic is more compliant with their medication, hopefully they're less likely to be in the ER or have a hospitalization, so there potentially could be savings as well. So a lot of different factors go into play, and those are just a few of them. But this is really just looking at what the raw impact is of limiting that cost share. So you can see here for the $10, again, this is really just looking still in isolation of those 9 categories. But you can see as we go from, a $10 maximum copay to a $25 maximum copay, the impact goes down. This is the split where it's $10 for generic, $25 for brand. and it is appropriately between those two. And then the richest of all of them is having generic go down to $0 and then a $10 maximum for preferred brand. So we do the same exercise with the state plan. But as I mentioned, the one difference was we both looked at applying it to generic and multi-source drugs, as well as applying it to all three tiers on the state side. So we put the summary together because it was a little bit easier to look at the scenarios side by side. So again, this is just looking at, for each of the 9 drug categories, starting with commercial, here is the 4 different cost sharing limits in the scenarios, and then looking at what the cost sharing impact and the plan paid. And the plan paid is really what House Bill 292 is getting at, is what is the cost impact to the insurance companies. Again, there's many reasons this cost might be different. Insurers might also choose to offset the cost of this by increasing cost sharing for another service. So it may not necessarily fall through to the premium impact. It could have other implications as well. But what we did, because this is just looking at the impact to the 9 categories, we wanted to understand what did it mean for the overall plans. So, going back here quickly, this is taking that 11.2, and this is it's split by the different lines of business, which we're pretty consistent across the board. But we look at it by the overall line of business. And so essentially what that means is we're saying, okay, you know, we might have reduced cost sharing by $2 million for the $10 maximum cost sharing scenario. But when we compare that to the total medical and drug claims for the plans that were included, and not look at it in isolation of just those 9 drugs, you know, for those 9 drugs, it's going to increase the plan paid by 11.2%. But if we look at the overall medical and drug costs for those plans, it's only going to impact it, you know, about 0.2 to 0.4%, depending on the line of business. So again, you know, these are averages, could be higher for some plans, some insurers could be lower as well. But these are kind of the averages for this. And then for the $25 copay, impacts are lower. Similar copays, again, with some of the rounding for this scenario. And then as expected for the $0 maximum cost sharing for the generic and $10 for brand has the highest overall impact, around 0.5%. And again, premium impacts will be a little bit less than the plan paid as well, but these should be a rough idea of what we would expect if all else equal. And then on the state side, very similar results. Again, as you recall, for the state, the majority of the copays were less than $10, and those that were more than $10 were mostly in the single source brand. So when we're applying this $10 copay, it's really not changing much. And when you actually look at it to the state plan in total, it's a very small 0.04% impact. At the 25 level, even a smaller impact. And so you're not, even for any of these scenarios, you're not seeing a huge impact. The $0 maximum for generic and $10 has a little bit more of an impact, the only significant one in this scenario. But then when we move to applying it to all 3 tiers, because as you'll recall, they had more brand utilization in their single source brand drugs, the impact becomes much more significant. And so again, we're applying this to all 3 of the tiered drugs. So it ranges from about a 0.3 to a 0.7% impact. And then the last thing I wanted to share with you, and I know this has been a lot of information, and then so we'll grab any questions after this, but the last thing I wanted to share is we also looked at the percentage of members and the percentage of scripts that are impacted. I know from working with legislators that's one of their questions always is how many members have you impacted? So again, this is really looking right now at the percentage of members who are impacted in these 9 drug categories. And for the report, we'll expand that a little bit more to talk about the percent of members who are impacted overall. But again, we just wanted to make sure that these numbers made sense to us when we looked at it. Again, given a very high portion of both the state and commercial cost sharing is already below $10, you can see as a result, for both the state and commercial, limiting cost sharing to 10%, only impacts 12% or less of the scripts in total, in average, and again, wide variation by for the 9 categories, and impacts about a third of the members on average. Varies again by drug category. Obviously, again, for the asthma category, a much higher percent because they had a much higher cost sharing on average, and similar on the state side, but a much smaller amount because of the higher lower cost sharing on the state side. So again, you can see obviously as the product at the richest level have a much higher percentage of scripts impacted and a much higher percentage of members impacted as well. And then on the state side, if you recall, when we just applied it to the multi-source drugs, we didn't have a huge impact. For at least these first 3, and you can see there's significantly less members and scripts impacted. And it wasn't until we got to this scenario where we dropped the generic cost share to $0 that you start seeing significant impact in terms of members and script. Again, they had a much smaller percent of $0 cost sharing scripts than the commercial, which is why you'll actually see a higher percent on the state side. But then again, once you then add in the single source drugs into the cost sharing limit as well, you'll see all of these numbers jump up significantly, and almost getting to the point where almost all the members are impacted in this final scenario. So I know that was a lot of information and a lot of numbers. I'm going to stop sharing, but if people have questions and want to go back to anything, we can, but otherwise I'll turn it back to the superintendent.
Well, thank you very much, Julie. Give you a chance to catch your breath. You've done a very thorough job, and you've done a thorough job of presenting that to everybody here on the call. I want to say again that I know the advisory committee greatly appreciates the work that Weekly has done to make sure we make whatever recommendation we do in an informed way with the best possible information made available to us. Let me open it up, and again, I will do as I have previously and say let's have questions first about either the data or the methodology. And if we don't have any such questions, then we would like your input on what you think of the various scenarios. What do you think of the findings, the results? And if you want us to be exploring anything else in particular to put in the report, we'd be happy to hear about that too. So the lines are open to anyone who would like to ask.
Superintendent, this is Trader with PCMA, and I want to first commend both you and Wakely. They've done an amazing job of assembling a lot of data. And Julie, I did not have the advantage of studying it, which I really think I needed, and also wished I'd paid a lot more attention in statistics class in college now. Very impressive data.
Now, when I went to college, Melody, I was delighted to learn that I could take one course, pass, fail, and that I chose that to be statistics for good reason.
For good reason. I appreciate that. They did not have that option when I went to school, so they did actually make me make a decent grade in it, but I'm going to tell you, I don't remember a lot of it, Julie. It was a long time ago, so I admire someone who can go through such detail here. The one thing that, before we get into the comments, Superintendent, you said you wanted to talk about the methodology. The one thing that I noted that you said quite a bit was there's a wide range of impact, Julie, when you look at the various plans. And I was wondering if the advisory committee and the superintendent will be looking at that data as it breaks down to that wide range. Because I think about, as a consumer, when I buy a product, you know, I may be buying it for different reasons. I may not be able to afford the best plan, but I want my family to have coverage. And so I buy it because the premiums are less. You're going to impact, I think you admit that you're going to impact the benefit structure here. So is the committee and the superintendent going to be looking at the impact on some of those lower priced plans, which I'm assuming, since you keep saying wide range, potentially could be more?
Yeah, I'll answer that, and then I can let the superintendent speak to what they'll consider. But yeah, we've been moving pretty fast, so we don't have the exact ranges yet. But we do anticipate, just based on when we summarize, like, everything we're showing you is aggregated at the insurer plan level. But once we start, slicing that up a little bit, we are expecting to see differences just because of the difference of what we saw. When we looked at like the percentage of scripts at the $0 copay level, that had a huge variation. And in talking to at least one insurer, they have a very robust $0, cost share program for maintenance drugs. So they will be less impacted than an insurance company that doesn't. And the insurer that had that $0 cost share program, it was across all of their plans when we looked at their plan design. So it even applied to like the bronze or the lower cost sharing plans. So again, for that insurer, it may not even be that impactful, by plan design for them. But for someone who doesn't have that program, it may be more impactful at the bronze level than, say, at a gold or platinum level when talking ACA metal levels, which hopefully you're all familiar with. If not, let me know. I can take a step back. But so we will be looking at that and presenting that information in the report, but we haven't provided it to the advisory group yet to consider.
But I think you're raising one important question, Melody, that we are struggling with, to be honest with you, and that is there's all kinds of plans out there. There are people in high deductible plans that may have to pay all of these costs up front. So there are a few short-term plans out there. So, we need to think through that carefully, and we have a short amount of time to do that. So if you have any thoughts as to how best to approach it, please let us know.
Since you already know how well I did in statistics, you know I'm really thinking hard about it.
I get that.
Thank you, Julie.
Okay, others with questions or comments, please speak up. Well, I know it's Friday afternoon. I know everybody's looking forward to the weekend, but these are important matters that we need input on. So I would ask anybody who's on the call to please speak up.
Superintendent, this is Sarah with AHIP. I had a comment for your second point, if now is an appropriate time to,
Sure.
You had said suggestions or beyond the data itself.
Sure, go ahead.
Okay, so first of all, I'd like to echo Melody's comments of thanks for this data. It's really helpful to look through it. Admittedly, I did not see it on the website, so I need to find it. So I'm trying to piece it all together and understand it a bit better. But it seems like from this data, it looks like the tools that carriers and PBMs are using are able to offer lower copays on these drugs and encourage utilization of these drugs. I see how insulin is different. There isn't a generic for insulin, but there are for these categories of drugs. So I worry about imposing caps where the current system appears from this data, again, to be making these drugs available at affordable cost sharing for consumers. So I know we have the 4 scenarios as part of this study, but I don't know if there's a way that we can consider a mention or a suggestion of our current system in the recommendations in the final report. I think that would be our ask at this time.
Okay.
Commissioner Toll.
Yes.
Hi, this is Legina Mendez-Harper from Prime Therapeutics. I echo what Sarah just shared. And one of the questions I had, and I wasn't sure if it was in your first bucket of comments or the second one. In looking at the key metrics, as Sarah kind of alluded to this, that you look at the cost sharing per script among these different categories. And for the commercial lines of business, the highest one is $37, which is, significantly lower than the issue with insulin that brought forth this legislation. Can you share with us what the committee considered in saying, we're going to include these 4 scenarios, one of which does not include the suggestion that, the market is controlling, the cost, the out-of-pocket costs for patients, the market's working.
Well, let me say two things. One, I think to the industry's credit, the statistics, the information here, the data, shows that plans are doing what we would all hope they would do, which is to make these maintenance medications financially available to most people. So, we will certainly note that in the report. As to specific recommendations, and which scenarios, we have not made any kind of decision on that. Julie appropriately asked for some kind of guidance about what are the range of things we should look at. And we came up with those 4 scenarios. I'm sure we could come up with another 4. But really, when we looked at the data, I would say the committee didn't see a need to get terribly complicated with all of this. And so, sort of following what was done in the passage of 292, we tried to structure things along those lines.
Okay. Certainly appreciate
we will give in our report some options. And a reminder to everyone, all this committee report will be is a recommendation. We don't have the authority to implement anything. That is reserved to the legislature and obviously to some extent to the governor's office. But we make recommendations to them and then they'll have to decide whether action is warranted or not.
So Commissioner Toll, this is Legina again with Prime. Just another quick observation. So part of the dynamics of prescription drug coverage is that you have the cost of the prescription being paid for jointly by consumers who have their out-of-pocket costs that they're responsible for, and then you have the insurer or payer who's picking up the difference. I think you guys did a fantastic job of recognizing that there'll be some cost shifting that occurs. One of the concerns that we've seen, and I'm just going to talk about Medicare Part D, is that they have certain classes of drugs that are considered protected classes. So it's similar to this kind of approach where they have to be included in coverage. And what we've seen, I know there's been a couple of JAMA articles recently that talked about the cost of drugs for those protected classes. When you insulate the consumer from fluctuations in cost sharing, that you start to see the cost of drugs increase. There's not a consumer influencer to bring attention to escalating drug prices. So I'm just wondering if that factored into any of the analysis here.
Julie, you want to take that one? We did talk, and you mentioned that there are a number of things to consider here. A, there are drugs coming off brand and becoming generic. B, if people, because of lower cost, can increase their pharmaceutical adherence, we're liable to have positive offsets on the other side by reducing complications, further deterioration of their condition, reduced emergency room visits and things of that sort. Do you want to talk a little bit about that?
Yeah, yes. Yeah, good points. Yeah, we didn't make any explicit adjustments to try to, we know that the drug industry is constantly evolving in terms of, patents expiring, new generics, and just new drugs. So we haven't made any, adjustments for that. That was one of the hopes of collecting 2019 data, is it would be hopefully recent enough, but we do recognize, especially for a couple of the drug categories, that there will be likely some new generic alternatives. So, but we haven't made any explicit adjustments per se for that. We'll make sure we note that in the report as well. Yeah,
Okay.
and I guess to your question regarding, the consumer pressures to keep drug prices low. Yeah, I'm not sure I'm in a position to speak about how much that would be impacted by this. I'm not, I think it all depends on, the current structure, to the extent that it's mostly copay driven plans. I'm not sure consumers know the actual cost of the drugs currently, unless they're paying for the full cost or it's a co-insurance type plan. But definitely understand that, yeah, there's some of that, the more the consumers feel the cost, the more they're likely to push back. It's just hard to know what the actual impact of that might be.
Superintendent, this is Melody Schrader again. If I could just add my concerns that Legina, I think, just stated. We certainly are concerned that, pharma is the one that sets the price of the drugs. That's nothing that we can do, although I hope and I appreciate you acknowledging that it does look like the tools that the PBM and the health plan are using is doing a good job of keeping the cost down for the consumer. I just have to echo the concern that I think Legina raised, which is if we can't use the fullest extent of those tools, the cost shifting would, in fact, be more significant than maybe we anticipate because of the fact that pharma can still raise those prices on the other side. So I appreciate your understanding and taking that into account as you're looking at your recommendations.
We will do so. I want to note that in such scenarios as where you've got a $25 cap, there's still an opportunity for the carrier to say the $25 applies to brand products, and we're going to use a lower copay or no copay for generic products. That is still a tool that would be available. We have that ability right now in existing House Bill 292 with respect to insulin. A carrier can distinguish within that $25 cap whether the covered individual is using a brand name or a generic product. That's perfectly fine. The other thing I want to emphasize is that 292 applies to generics and preferred brand. We're not considering any scenarios in which the copay cap would apply to non-preferred brands.
Janet, thank you for that distinction. That's very helpful as you think through this. Thank you very much for highlighting that.
You bet. Other questions or comments? Anyone? Speak up.
I do have one last question. I mean, as this data is still pretty fresh to me, and thank goodness we do have someone in our office who did much better in statistics than I do. I will be sharing this with her. If we have additional comments, may we make them at the first of next week? I know you're on a very tight time frame.
Yeah, we would need to get something no later than Tuesday.
Thank you. Thank you.
Now, we've asked Julie to repeat this conversation twice tomorrow and 3 times on Sunday to ensure that everybody has a chance to get this.
Commissioner Toll, this is Legina from Prime. Could you or your staff please help us navigate to where this newest version that was presented is accessible on your website?
It's not yet on the website, but we will do that today.
Okay, thank you.
And Superintendent, just in case I don't get a chance to email, I'm going to make a couple minor updates to the document and I'll resend it for a final document to post.
Thank you. Okay, any other questions or comments? Going once. Going twice. Please see your chat. You can send comments to Colin. And his email is there.
Superintendent Tolt, one question. This is Yolanda with True Health. So since there are going to be some minor edits made to what we received today, will the carriers be getting an updated version separate from what's going to be posted, or should we go and get it just from the site?
You'll get them from the site.
Thank you.
And then we'll release our report probably Thursday afternoon. And it will go up on the website then Friday morning.
And I'm sorry, Commissioner Toll, could you share just one more time what the what's included in the report?
I'm not sure I understand the question. We have to respond with our recommendations and our report of what our examination showed.
Okay.
And that's what we write. There isn't a format that's required by the statute.
Thank you.
Sure. Any other questions? Well, thank you all. I really appreciate your interest and your time today. Julie, my mega thanks to you. You always do a great job. And to those on the call, if you have questions, please, or comments, please send them on to Colin or to me. My thanks. Have a good weekend, but stay safe, please. Stay safe.
Thank you.
Thank you.